Thanks everybody for joining. This is Carol from the STS. Today is the STS National Database ACSD QI series, July 17th. On the call with me from STS, we have Nancy Honeycutt, Emily Conrad, Paul Meehan, Sydney Clinton, and of course the wonderful Melinda Offer. We're not so much focused on QI today. We are going to go over a couple things with some STS updates. An upcoming IQVIA release for July 27th that I would like you all to be aware of, and then an exceptional risk update. We'll talk more about that. Please be sure, I'm going to close down the chat box now, but please be sure to go ahead and put your questions in the Q&A if you have any, and we'll get to them towards the end of, yes, Kim, we're going to discuss EREC today. So put your questions in the Q&A and we'll get to those after the presentations. And moving on. So the July training manual is posted. AQO registration is open, and we have a new procedure, two new procedure identifications coming out, which will be called PROC ID 9 and 10. This will be multi-valve, will be PROC ID 9. PROC ID 10 will be multi-valve with cabbage. Oh, sorry about that. More information is going to come on those. We will have updated PROC ID charts and a update to the national report overview, which Nancy and Melinda are working on. That will be posted before Harvest 3 closes. The multi-valve PROC IDs are not going to be star ratings. They will be risk-adjusted results provided in each of the analysis reports. It's looking at AVRs, mitral valve repair, mitral valve replacement, combinations of valve procedures with or without cabbages. So we will provide more information on that. It's coming soon. It will not be risk adjusted, so it will show up in your Harvest 3 reports. IQVIA is also building it out into the non-analyzed reports, your participant dashboard, and other areas within the non-analyzed report. So we'll have those coming out soon. And then shortly behind the multi-valve, we're going to have a new star rating come out, which will be produced for Harvest 1, which will be a multi-procedural composite measure. And we'll go over that in more detail at AQO. And then following AQO, we'll share information on that. We will report multi-procedural out as a star rating with Harvest 1 and 3. And then we're expecting to add that into public reporting, not right away. So I'm not expecting it to be in public reporting. Probably we usually report out new composites for a year before we give sites the opportunity to voluntarily report those outcomes out in public reporting. So more information to come on that. Multi-valve is right around the corner. Lots going on here at STS. So important dates, July 17th, here we are today, July 27th, we're expecting the Harvest 2 report to be released. So that Nancy and I just did a review with IQVIA today. The report looks good and should be ready to be released. And we didn't find any discrepancies between what we were expecting to see in the reports. So coming soon to you on July 27th, that report will be released. August 7th, we have a monthly webinar. August 24th, we have a quality improvement webinar. We'll revisit the ventilator QI that we've been working on and provide kind of an update on that. We're going to then, following the vent update, we're now going to switch our focus more to blood usage, which will start that quality improvement series on September 18th. This will be for intra and post-op blood usage. So really looking forward to that transition. And then August 23rd, we have Harvest 3 closes, which will be OR dates through June 30th. August 27th is the opt-out for Harvest 3, ends on August 27th. We have AQO in Nashville, September 11th to the 13th. The Adult Cardiac Day is September 12th. If you have not registered, I urge you to register. Also, if you are a third-party vendor and joining our webinars, we want to encourage you to register for your company to have a booth at our meeting. Please reach out to me or Emily Conrad, and we'll be happy to put you in contact with our marketing team. We're really looking forward to having some vendors with us this year as well. It's a great way to network with your customers. Again, Harvest 3 closes on August 23rd. It is a star rating period. And then AQO, September 11th through the 13th. Oopsie. Its registration's now opened. Housing, there is no deadline for registration. However, the housing deadline is August 21st. So if you're planning to go and you haven't yet reserved your room at the hotel, I think it's at the Lowe's Vanderbilt. If you haven't already reserved your room, you'll need to do that by August 21st to preserve the rate that's set forth for the meeting. In-person pricing and virtual pricing. For the virtual pass, we will have some content available ahead of the AQO that will be posted on the platform, on-demand content for both in-person and virtual attendees to have access to that. And then the rest of the content from the live meeting will be posted after. Usually it takes a couple weeks to get that posted up to the platform for the virtual attendees to be able to view it and for the in-person attendees to have access to it again. Next year, we've been discussing here at AQO about what to do in 2025. It's likely that we're going to continue with our in-person meeting just because that networking is so valuable to everybody. So we will have an in-person meeting in 2025. Location hasn't been decided yet, but more information will come on that. And then the IQVIA updates for July 27th. Like I had previously said, that Harvest 2 report's expected to be released. So that's coming right around the corner. And I wanted to talk to you all about this executive summary update and the current harvest missingness. So I have that pulled up as soon as I find it. There it is. So on the current harvest missingness, this is the executive summary. When you first log in, you're able to see your star ratings, longitudinal star ratings across time, a few outcomes for all of the procedure types. We're looking to expand this, so if you have any suggestions on other outcomes you think would be helpful at a quick glance kind of thing, feel free to send those suggestions to Nancy and myself, and we'll put them on the list for IQVIA. And then the important thing here is this current harvest missingness unknown composite rating. The idea is that this is to give you give you input into how your data looks for the harvest that's upcoming or the current harvest period that we're in. So right now we're in harvest 3 period. So these should be reported out to you looking at rolling 12 months. So it would be July 1st, 2021 through June 30th, 2022, July 1st, 2022 through June 30th, 2023, and July 1st, 2023 through June 30th, 2024. However, currently these are reported out just looking at the calendar year. So it's only looking at a partial year of 2021, the full year of 2022, full year of 2023, partial year of 2024. And it's not looking at the 3 rolling 12-month periods that we use to determine eligibility into analysis. So IQVIA is fixing this, and it will be updated on July 27th. If you have already submitted data for Harvest 3, you need to go back in and check. If you're using this, just go back in and check to make sure all your boxes are green. If you have any in yellow, address those. And don't forget that you can drill down into the missingness column when you get down there. You can drill down, your case list will populate here if you have any in the missing column. So now again, this is currently showing based on calendar year. It will be updated on July 27th to reflect the 3 12 rolling month periods that we use to assess missingness for analysis. And you'll need to go back in and recheck your data if you're using these. We'd previously reported out that this is the second harvest or third harvest we're using this report. The first harvest was harvest 1 of 2024. So we had all full years. We were looking at full years of 2021, 2022, 2023. So this report made sense. However, now that we're into harvest 3, we needed to update that to make sure we're looking at the rolling 12 months for the 3 timeframes. And so that's coming July 27th. Also, be sure to still continue to look at your other reports, your other operational reports. including the participant dashboard, the missing variable report, and the harvest summary report, like we've reviewed in previous webinars. And as we get closer to Harvest 3, we'll have a webinar dedicated to data accuracy, sharing your data accuracy, and making sure you're all good to go for the Harvest close. We'll have that webinar prior to the Harvest 3 close. So I wanted to share that. And so that's my IQVIA updates. And then we're going to go into exceptional risk. And exceptional risk. So the STS surgeon leadership has, over the last few years, we have been discussing with the surgeon leadership ways to recognize that there are some cases that are performed that are considered exceptional risk, where all of the risk of the patient is not completely captured within the current risk models. And we'll go through a list of examples. So we wanted to give sites a way that feel that their case is of exceptional risk, meaning things that are not currently captured within the risk models, a way to have those cases reviewed by their peers through STS surgeon leadership and potentially excluded from analysis. So this new process is going to allow surgeons to seek individual case exemptions from the database analytics for extreme or exceptional risk cases with rare comorbidities. Again, things that are not captured within our current risk models. Notification was sent to sites that this process was starting. We sent that notification on June 14th. It's not intended to influence patient care decision-making. The case has to be submitted before surgery. Cases that we review or that we receive requests for review after the surgery date will not be reviewed. Those will automatically be denied. It's a way to prevent gaming within the system. And we also, again, don't want to influence the patient care decision-making. So because of that, we'll review the cases, but the surgeon leadership will review the cases, but the decision will not be communicated to the site until just before the harvest closes, not prior to any surgery date. So your site, if you have a case like this, they'll submit a web form, and I'll go through all of that just a little bit here. They'll submit a web form to us. Nancy and I receive a copy of the web form. We reach back out. No matter who submits the case, we'll be able to identify the data manager through our records at STS. We reach back out to the data manager, letting them know that a case was submitted by the surgeon or somebody else at their facility. Data managers have submitted cases to us as well. We let the data manager know a case was submitted. We ask for additional information. Nancy and I gather that information. We ask for the operative date. And then we ask that once the operation occurs, that the op note and STS record and STS patient ID are then sent in to us. So when the surgeon submits the initial request, STS requests additional information. We need that information back to us. It must come back to us within 3 business days. It has to be de-identified, no PHI, no hospital surgeon or other provider, or any other identifying information to be included. Nancy and I further go back through all that information and make sure everything is redacted before we send it over for review. And sorry about that. Only send requested information. So we'll ask for specific things like TEE reports or echo reports, cath lab, HMPs, any consults. We might ask for specific consultations. We might ask for specific ultrasound reports, specific CAT scan reports. Only send the information requested, de-identify it, no PHI, no other identifying information on that report. And then following surgery, we ask that the op note, the STS record ID, and STS patient ID are sent to us. The STS record ID and STS patient ID are not available until that case is entered into the vendor software or into direct data entry through IQVIA. So that way we ensure that that case is still being entered into the warehouse, or at least into your vendor software. And the reason that's important is because we still want these cases in the warehouse. We still want them sent over to STS when IQVIA sends over the harvest file with the data for analytics. When that case comes to us at STS, we remove it from analytics, but we still keep it in the warehouse data. And then failure to respond to our requests when we reach out to you, if we don't hear back from you within 3 business days. Of course, we'll try to reach out to you again, but it's really the site's responsibility to respond to STS for additional information. If you're going to be out of office, put an out of office message on, so we're aware with somebody else we can contact. But if you don't respond to us within the 3 business days, you're going to lose your chance to continue participating in this process. At least the first time that you don't respond back to us, it'll be perhaps a 6-month or year type of penalty. And then after that, the penalty can go up to no longer being able to participate at all in this process. The other things is the cases, again, they have to be entered into the data warehouse and have to be submitted to IQVIA. So entered into your vendor, if you use a third-party vendor, entered into the vendor software, still include that case in your upload to IQVIA. When that case comes over, when all of the data comes over for harvest from IQVIA, STS Analytics Center will remove that case from analysis, and it will not be contained then in any of the reports, your benchmark reports, your risk-adjusted reports, any of the analyzed reports. It will not be contained in that report, and it will also not be included in public reporting. And there will be a case discrepancy between the raw and analyzed dashboard. So if the case you're submitting was an isolated cabbage case and it went for review, surgeon leadership decided that that case would be acceptable for exceptional risk, Nancy and I will inform you. We'll keep the STS record and patient ID. We share that with our analytics center. The data from IQVIA comes over for the harvest. Our analytics center removes that specific case. The case count in your participant dashboard is your raw data, so that case will still be in there. However, when the analyzed data comes back, it will be removed. So you'll have a case discrepancy, a case count discrepancy, but you'll need to be aware of that. And we have records here at STS to support all of that. Surgeon leadership will provide an annual update on the types of cases removed from analysis. So this will be done on a yearly basis, where they will go through, review the cases in total that were removed and report on those via manuscript. I think anything you want to add here, Nancy, or to this, what's the data manager's responsibility is on this?
Yeah, excuse me. You'll be getting an email from either Carol or myself requesting more information and your records. That will be encrypted. Please reach back out if you can't open that and send back your records encrypted as well. And again, only send the requested information. I know a lot of times when you pull records off of some of the medical records vendors out there, that it'll load a lot of pages. Try and make sure you're only sending us the pertinent information. And then also, Carol already mentioned, just make sure that the information that you send us is de-identified, and that includes any hospital information.
Yeah, like I think one example is, Nancy, the banner for the hospital populates on every single page that was exported and sent to us. And we need that removed from every single page, so there's no hospital identifiers. Nancy and I know who's sending the information in, and we know who the hospital is, and we know who the surgeon is, and we know all of that. But when these cases go for review to STS surgeon leadership, it's a very blinded process. They don't know, they don't have access to any of the PHI. They don't know who the provider is or who the surgeon is. They don't know what hospital it's coming from. And we really try to make, really try to help them remain unbiased in their review. So this helps us in that work of doing that. Good points.
Yep. Well said, Carol.
Yeah. So here are a couple examples of cases that would be considered for to be of exceptional risk. This is not limited to, and it's likely that this this list will evolve as we receive more cases. If you aren't sure if a case meets exceptional risk, but you still, you're thinking, not you, but you and your surgeon or whomever is submitting it to us, this case isn't fully accounted for in the risk models, which means that you'll need to understand what the risk variables are and how the risk models work. You can still send it in to us. Nancy and I can do the preliminary review on it, and we'll request more information as needed. Again, the request has to be sent in to STS before the surgery date. If it's sent in on the same date as surgery, I will ask you for your OR log to compare times, just to make sure that we're not reviewing anything after surgery occurred. And it's not an ask to perform surgery on a patient. It's an ask to have the case removed from analysis. So not intended to gauge or not intended to aid in patient care decision-making at all. Here are the case examples for fourth time or greater reoperation, epicardial or intracardiac operations, hepatic cirrhosis with known portal hypertension by clear varices on a portal ultrasound. So this is where we may ask for ultrasound information. Listed for liver or lung transplantation. Kidney transplantation is not an acceptable exclusion. Prior cardiac or lung transplant. More than one limb amputation greater than the phalanges. Prior pneumonectomy, implanted permanent mechanical circulatory device, RVAD, LVAD, or total artificial heart. So these are the types of cases we'll be reviewing. Again, if you have something that you think falls outside of the risk variables that we're currently using for risk model stratification, reach out and fill out a form. And I'm going to show you that form now. So that's actually the end of my presentation, but I do want to go through, this, if I can find it quickly. So under the research and data for data managers, the adult cardiac section, you'll see this drop down here for exceptional risk exclusion request. And submitting a request does not automatically mean that that case is going to be excluded from analysis. We, like I said, Nancy and I will reach out to you for additional information. When we gather that information, we do a preliminary review to see if there's anything else that might be helpful for the surgeons to review it. We then put that all together, make sure it's all redacted, no identifiers at all included. And we send it out blinded to the surgeons, STS surgeon leadership, who reviews that case. They review it individually. They're not able to see how others are reviewing it. And then we combine the responses and then review them as a team. And then a decision is made. Once that decision is made, it is final and it cannot be adjudicated. So this is the exceptional risk exclusion. Adult cardiac index operations. So we're not looking to review things like aorta cases. These are your index operations, your isolated CABG, AVR, mitral valve repair, replacement, CABG, AVR, CABG, MV repair, replacement, and then of course, going into the multi-valve procedures, which are coming up to be reported. So those are the cases that are up for review. We're not looking to review things like any aorta cases. So you see that on here. And then if you believe the case meets exceptional risk criteria, you would like it reviewed by the committee prior to the date of surgery, you complete this form, and we'll go to that form in 1 second. We'll contact you, the data manager, for specific case information documentation to determine if the case meets exclusion requirements. You'll be notified after the final decision after the date of surgery. If the case is approved by the committee as exceptional risk, the complete in-hospital and/or 30-day data, including mortality information, still has to be submitted. And then it will be removed from the outcomes reporting, including public reporting. The same list here of examples. This is not an inclusive list and may likely evolve. Again, criteria will evolve as risk models are modified for new and more frequent high-risk procedures. We expect these cases to be rare, highly unusual, and infrequent. And then you'll still need to submit all of your cases into the data warehouse. including these cases if they're approved for exceptional risk. So the form, we'll open up here, similar information at the top. A couple attestations that you understand the case aims to adjudicate extremely high-risk patients from database analytics, and it's not intended to influence patient care decision-making. The STS Exceptional Risk Exclusion Committee finds the case to be an exceptional risk. It will be eliminated from STS Harvest Analytics, STS Risk Adjusted Results, and STS Public Reporting. And it's important to understand here that some cases that are high risk, they are already accounted for appropriately or mostly appropriately within the risk modeling. And this goes into your observed to expected rate. So it would, it influences your expected rate. So if you have a good outcome for a very high risk case, that's good for your site's observed to expected overall outcomes, your risk adjusted ratings. So you're not going to want to exclude all of your cases because you could actually harm the reporting, the risk adjusted results for your site. So you have to be very thoughtful about this. Your surgeons need to be very thoughtful about this and how it can impact your overall outcomes. So it's there's a balance there that you all need to decide what's where you want to fall within that. The other one, I understand that STS may require additional information. STS has to receive a response within 72 business hours, 3 business days, or that you may fail to jeopardize the candidacy of your site from future participation in this exceptional risk program. I understand that the outcomes of the submitted case reviewed by the committee is final. No further adjudications or appeals will be accepted, and this request cannot be rescinded. So once you put this request in, that's it. That case is coming, is going to be reviewed. Potentially will come out of analysis. Even if that patient has a great outcome, you put this request in and the patient, was very high risk going in, exceptionally high risk going into surgery, but that patient has a pretty good outcome. After surgery, post-op course, it goes well. You cannot rescind this request. It has to, that case still will have to be removed from analysis if it's approved, deemed to be of exceptional risk, and the committee approves that for exceptional risk exclusion. So once it's in, and just keep that in mind. And then when you go to fill out the form, you select who's filling it out, the surgeon, data manager, or other personnel, which could be like a APP, advanced practice for provider. If you're filling it out as a data manager, it's going to ask you your name, your email, the name of the surgeon performing the surgery, your hospital name, city, state, those are all, if you want to include them, you can, you don't have to. And then a brief de-identified clinical summary, no PHI. So just basics about what the case, what the patient or case is, and reasons why you feel that it is of exceptional risk, or your surgeon feels that it's of exceptional risk. The surgeon sees something similar. Just the surgeon name, email, hospital name, brief clinical summary. And then if the surgeon submits it, we can find where that surgeon practices through the hospital name. And then we would have contact with the data managers who Nancy and I would reach out to. And then other personnel, very similar information. And we will find who it belongs to. And then the planned date of surgery is optional. If you provide that, that's fine. Otherwise, Nancy and I will ask it in an encrypted email. So then Nancy and I receive these reports. They come directly to our email, and then we take it up from there. So anything to add? Did I miss anything, Nancy?
I don't think you missed anything.
Okay. Let's see.
It sounds good.
Okay. Well, that was a half an hour. So let's see. We do have some questions, so let's go over to those. And is there, Emily Conrad, this is for you. Is there a deadline to register for the virtual AQO?
I just checked with Elisa, who's our meetings gal, and she said there is not a deadline, but she suggests doing it earlier than the day of, or or whatnot, just so that we can get you the information as soon as possible. So I would say
Thank you. And then unfortunately, I'm not allowed to register for AQO until abstracts confirmed. Is there any updates on the abstracts that were submitted?
Yeah, so that abstract review ended on last Friday, the 12th, and right now we're getting the letters together for the authors on either acceptance or resubmission or rejection. And the authors will be receiving notification this week. If your abstract is submitted for if we want to see more information from you, it won't be like the process will not be final until mid-August. So I would pass that along if there is an if your registration is dependent on that, it'll still be another month or so. But you can follow up with me regarding the abstract process.
Okay, thanks, Emily. Do you mind putting your email in the chat box for Heather?
Yeah.
Okay, thank you. Is there a single day option for virtual attendance?
No.
No, it's multi-day. We both put them all together. Okay, and now I'm gonna go into the EREC questions. I think those were everything for AQO, Emily.
One more about CEs. There will be continuing education for both in-person and virtual.
Thank you. I missed
Yeah.
that one down at the bottom.
That's okay.
Carly's asking, when will vendors get the specs for these new procedure categories? So we have a couple things pending that need to have vendor updates. We're working internally to develop a way that we don't have to require vendors to go through certifications for these new risk models and to provide other updates to them. So as we're working that through, it's probably still going to be another month or so until we have a pretty strong answer on that. Paul Meehan, are you on?
Yes, I am.
You want to take that one?
I
You wanna
think you
start?
covered it.
Okay.
We have some ideas that we're trying to finalize before we talk to the vendors. The vendors will eventually be able to provide the new scores for you, but just when is still being determined. We're trying to determine how, and then when will come after that. And so be a little while yet.
Okay, thank you.
Mhm.
Yeah, but coming and hopefully it'll be a much
Yes.
smoother process, right?
Yes. Yep. And they will
Well,
get certified to make sure that it's being the scores are coming correctly.
okay, thank you.
Mhm.
Sorry, I saw your name. What if our site does retrospective chart review? Data managers are not always aware of cases prior to OR. So these cases, if you want the case or your surgeon wants the case reviewed for exceptional risk, and it must be submitted before the patient goes to surgery. Your surgeon can fill out this form. So it's you can definitely share this information with them. The notification went out to surgeons and data managers on June 14th. So they received this, but you can also share this with them. Show them where the link is at if they have a patient that they want reviewed for exceptional risk. It must be submitted before patient goes for surgery. No exceptions. How was the EREC notification sent on June 14th? It was sent to data managers, primary and backup, and to the surgeons. If a patient had a CABG plus LVAD, but unfortunately had a mortality within 30 days at an outside hospital, wanted to confirm that this will not count towards isolated CABG mortality. And we would need to know when that LVAD was placed, if it was placed at the same time of the CABG or if it was placed post CABG. Need more information on that one.
Send that to me.
Yes, send it to Melinda, the FAQ mailbox. Did you discuss the frailty score process? No, we did not. There's no update on that at this time. My site operates on high-risk cases at least monthly. I am curious how the excluded cases impact the expected to observed. I expect the ease may decrease depending on the patient's risk factors. Yeah, that's correct, Amy. You have to balance this. We have a lot of sites that are, transplant centers that are doing a lot of transplants. They're seeing their patients for CABGs. Patients often do well following their CABGs at these facilities. And it wouldn't make sense for them to want to exclude all of these cases from their expected rates. or, have them considered for a possible exclusion from their expected rate. So it's something that you would have to discuss with your surgeons and they would have to make that call. I hope that helps. How many ERAC cases do you expect per year? I think the numbers are going to be very small. I don't know. We'll know more. We'll know more in, I wouldn't say more than 100, but the numbers again, we're expecting it to be very small. And the surgeons are very aware of how our risk, the surgeons that are reviewing, of course, are very aware of how the risk models work, are aware of current practices at facilities, and it's going to be interesting. It will be reported out annually. So we'll have more information on total case counts that were submitted probably next year that we can share. Will we need the record and STS ID within 3 days? So that's a good question, Carly. We know that sites who sometimes use abstraction companies or abstract retroactively will not have that STS and patient ID, the STS record or patient ID within 3 days. So we have, Nancy and I keep track of all of the sites we're working with on these cases. And we follow up with you to get that information as soon as possible. But we're aware that some sites are not able to get the STS patient or record ID within that time frame. Is participation in ERAC jeopardized if the proposed surgery submitted does not occur, is canceled or changes? A planned ISO cab ends up being a cab plus aorta. So we could definitely, I think if you have a case that needs to be reviewed, Nicole, we'd definitely be happy to review it. And we would make a decision. The surgeon leadership would make a decision then. When did you say the ERAC was start? So we started it on July 14th. The process opened right away when we sent that email out. We got our first case for review on July 15th. Can you repeat the new star category information and dates of release? So the new star rating that's going to come out will be, I don't have any slides on it actually. The new star rating that will come out will be the multi-procedural, and that's not expected to come out until Harvest 1 with the Harvest 1 report. We're going to have information available prior to that at AQO, and then we'll present some of that on a webinar following AQO. So you're aware it's a multi-procedural, it's kind of a combination of all of the procedures that are already reported out. And it will include the new multi-valve procedures as well. While you're working on updates with the vendors, could you also update the valve dropdown so we have less extra work to enter commonly used valves into the REDCap application? Thanks for the question, Tina. That would require a spec upgrade, and we are not doing a spec upgrade at this time with the vendors. Same time as cabbage. Hold on, let's see. Melinda, do you want to, I think we said to submit that. It's a cabbage plus a VAD that I'm assuming.
Yeah. The big question here, Naseem, is was that LVAD planned to be inserted at the same time they did the cabbage, or was it unplanned and inserted during the same setting, but after the procedure and it was unplanned? So that's the big question here. So if you want to respond whether it was planned to be done at the same time as the cabbage,
meaning that it was on the consent.
yeah,
meaning
on
it
the
was
consent, going on the OR, they're going to put an LVAD in, versus whether it ended up being unplanned at the time of surgery. Then, well, if it's planned, it'll be removed from isolation. If it's unplanned, it will not be removed from isolation.
Yes. Thanks, Melinda. Just to clarify, we should include all cases to the database. There are no exclusions from submitting to the database, correct? That's correct. All cases should be still submitted to the database. This case would not, this case should, if you send in an exceptional risk or your surgeon sends in a case for exceptional risk and it is approved by the committee, that case still needs to be entered into the database and sent to IQVIA. And then your next question, Angie, regarding in the vendor software, that there's a question, should the case be included in Harvest? Paul Meehan doesn't like that, and they should actually not have that available for you to choose.
I
But-
already came off mute.
But Paul, I'll let you discuss, I'll let you take that one further.
Yeah, that's a definite no-no. Vendors are you're supposed to say, I want to extract my data. You give 2 dates and it pulls all your records in between those 2 dates. Whether they're used in analysis or not is determined by analysis. Your vendor should not be giving you that option. And if they are, you can email me directly and I will talk to the vendor and make sure they remove that.
Thank you. So all cases submitted in all cases should be submitted pulled down from your vendor software, exported from your vendor software and uploaded to IQVIA. All of those cases go over to STS Analytics, who then determines which cases go into analysis and would pull out these approved exceptional risk cases prior to the cases going into analysis. I received an appropriate EREC case referral from an APP, but it was post-op. If we change our process to have the clinician access and complete the web form, but they forget to notify me, please confirm you will reach out to me, the data manager, for additional information. Yes, that is who we reach out to. We will CC the person who submits the form, but we reach out to the primary and backup data contacts. So you're included in the loop very early on in the process. Do the surgeons know about the EREC, or do we need to notify them? They were notified via email, but sometimes they don't always read their 2000 email inbox. So I would say that if you want to update on them on this, you certainly, I don't think that would hurt. But just, again, be aware that this plays into your observed to expected rate. So if these cases are removed from analysis and they have good outcomes, they're not going to help your site with your observed to expected. My form does not allow a future surgery date, so I question how we enter the case. So Michelle, you would give us the STS patient ID and STS record ID after you enter the case into your vendor software. And that's fine. Nancy and I will work with you on that. We just need to know that you have a case for review. We just need to know that you have a case for review or that you would like reviewed ahead of the surgery, before the surgery date. And then all that other information, we'll follow up with you. We'll get more of the records on the patient. And then usually it's a few emails. We'll get more of the record. We'll ask you when the surgery date is. Some cases that we have reviewed have are still planning surgery, or they don't have a surgery date because the patient is healing from something else. And then, we keep notes on that and we will follow up with you, or we expect you to follow up with us. Either way, we'll get that information from you and we'll work with you on that. Melinda, that case was unplanned with the VAD.
It's an isolated cab.
Yeah. Thank you. So the individual multi-valve such as AVR, MVR, cabbage won't be a star rating, but they will be included in the multi-procedural star rating. Yes, that's correct. And it starts Harvest 1. Does it go back 3 years? Yeah, we'll go back 3 years on that, and it will start with Harvest 1. More information, again, will be provided at AQO, and then subsequent webinars. The subsequent webinars that we have will share information on that. That is correct. The multi-valve will not be a star rating. It'll just be risk-adjusted results, but the multi-valves will be included in the multi-procedural star rating composite. There. You're welcome, Angie. And then one more. I have a cabbage only patient that had to have ECMO placed and was transferred to another hospital for further care. I have been trying for a month to get the records with no success. What do I do if I can't get the records? If you want to email me and Nancy. Nancy, do you mind putting our emails in the chat box?
Sure.
Email me and Nancy, and we'll share some information. We'll be able to see if we can help with facilitate any conversations. If it's an STS participating site. That's we're your last resort though. So as long as you tried everything else, feel free to reach out. But we're not your first option because we're busy. But we want to help. All right, Darlene. About the vendor, include an STS harvest, yes or no, in the case form. Some sites abstract non-STS eligible cases for internal trackings, re-ops that would be not submitted to the STS, but site would still like to track at least some of the data within the data warehouse.
Should still be able to send it to us, and we determine that it's not something that we're analyzing.
Yeah, these are the kind of the sites that send in cases, same admit, same discharge date, different
Mhm.
surgery dates, or same surgery date, different OR times. So I think we have checks in place within our analytics to pull the most recent case if you send in 2 DCFs to us. So that should be okay. And then can you explain how coding unplanned ascending aorta replacement due to unsuspected disease during a planned CABG would impact the category of procedure, still isolated CAB or other? So I will show you. This is going to stay in, or this should move into the other category since it's unsuspected disease done during a planned CABG. Agree, Melinda and Nancy?
Yeah, if it's really unsuspected disease.
Yeah.
I always like to look at those op notes.
Yeah,
So-
it would be, I would, if you really have a question on this, Jill, and you have a specific case, it's probably good just to send it into Melinda with the de-identified op note so she can review it.
And then it depends, is it just an aortoplasty? Is it, I mean, there's a lot of little details. So sending me the op note is probably the best thing to do, Jill.
She says she'll send the app note, thanks. Okay. And then I see a couple hand raised, Nicole. Feel free, and somebody else, B103780. You're able to talk. If you would like to talk, go ahead. And okay, you might want to check if you're muted, but if you don't have anything, not able to come off mute, you can feel free to put it in the Q&A. Okay. Any other questions? Look at that. We could finish 10 minutes early. We never finish early.
That's amazing.
Oh,
You just thought you were done.
I thought I was done. Wait, hold on. I joined late and did not get the beginning of the webinar. When will the recording be available? So the recording, we'll send this over today or tomorrow to our marketing team. But we have 10 minutes, so I can redo the beginning, Grace. Just a quick, and if anybody wants to hop off, go ahead. But July training manual posted. Be sure to register for AQO if you haven't yet. And the multi-valve plus or minus CABG, which will be Proc ID 9 will be the multi-valve. Proc ID 10 is the multi-valve plus CABG. Is a new risk-adjusted cohort will be reporting out starting in Harvest 3. It is not a star. Starting in Harvest 3, it is not a star composite measure. It's just a risk-adjusted results. And then there's the date. The recording should be posted within the next week. Will the new star rating multiple procedure category AQO session be available for the virtual platform? Or will it be one of the recordings you have to wait for? I think it's one that you're going to have to wait for, but Emily can correct me on that.
What talk is that?
Isn't Dr. Bowdish doing that one, Carol?
Star rating multiple procedure.
Is he doing that one?
Let's see
That's in
what
live, isn't it?
Yeah, if it's live, then it'll be one that it'll be available after the meeting in Nashville.
Thanks, Emily. Will vendors get specs to the isolated AVR MVR cab in advance of Harvest 1? You want to take that one, Paul? If he's still on.
I'm still here. Will the vendors get specs for isolated way in advance of Harvest 1 2025? At
Oh,
this
wait, let
point, I
me take
can't.
this.
Yeah, I
let me
can't.
take
I
this.
don't know at this point.
Yeah, that's gonna be reported out in Harvest 3, and it is not a composite star rating. It will be just be risk adjusted results. On your IQVIA dashboard, you'll see where it says all under. And we'll do a better review of this one when it's available. Let's see if I can pull it up real quick. Under your risk adjusted dashboard, it won't be a new reporting in the star reports or the quality ratings details, or quality rating trends. It will be a new item underneath the risk adjusted reports and the benchmark reports. And you'll see the tabs there for multi-valve and multi-valve plus cabbage. When will this EREC take effect? It went into place on right after we sent out the email on June 14th. Is multi-valve just MVR or MV repair? It's both mitral valve repair and mitral valve replacement. Will Proc ID 9 and 10 include the prior 3 years data when it's released in Harvest 3? Yes, it will. It will include the prior years data. The 3 years data. Proc ID 9 and 10 will have no star then. What is the new star rating that was mentioned? Proc ID 9 and 10 are not going to have star ratings. The new star rating will be a multi-procedural composite that will come out with Harvest 1. So it will include, it will be a roll up of all of the isolated cab, isolated AVR, replace plus cab, the mitral valve replace and plus or minus cab, mitral valve repair plus or minus cab, and then the multi-valve will all be rolled up into one composite measure, and that will be the star rating. But we'll report that out to sites. Usually we try to do that for a year prior to doing any type of public reporting with it. We want to be able to check our data on those cases, and it's difficult to do when we can't isolate them in our vendor software, which is why I'm asking. Yeah, I understand. So again, it'll be a combination of the roll up of the procedures and including the new mitral valve ones, which your vendors don't have either. But we're trying to facilitate that with them of sharing new models in a way that we have never done before, but hopefully we'll have an update on that within the next couple months. We will have it built out on the participant dashboard prior to the Harvest 3, prior to Harvest 1 closing. So you will be able to see both multi on the participant dashboard, missing variable report, Harvest summary report. You'll be able to see under the procedure tab, you'll have a selection for multi-valve, and you'll have a selection for the multi-procedural. Multi-valve will be first, and then multi-procedural will come after Harvest 3, so probably sometime around after Harvest 4 closes, so it's included there. So that should help you with cleaning up your data. Will we still receive individual star ratings for each? Yes, the star ratings are not changing, and just that we'll be adding one for multi-procedural. The IQVIA report does not show mortalities in the OR. This makes it very hard to verify mortalities. I'd have to better understand which report you're talking about, Michelle. I assumed that it would have been on the I assume that it would have been on the participant dashboard, but let's double check and see. I mean, we do have 4 minutes left. On the non-analyzed report, so let's check and see. And I want to pull up. I'm just going to pull up the data collection form just to see where we're looking. Sorry for the scrolling, everyone. I always apologize for my scrolling after I was told I have angry scroll. So this is this post-operative patient expired in OR. Let's double check. If it's not there, we can certainly something we can talk to IQVIA about adding in. And I also want to check out. I also want to check out something else here on this. So we have it there, and then I wonder, I don't know if you can infer it or not from this died in hospital one. But let's see what we have. So this is the, where it should be located is the post-op events for the died in OR, and it's, oopsie, it's not there. Sorry about that. It's not there. And then in the discharge mortality. So we can definitely add it, we can definitely add it for a request for IQVIA to add that in for us. And then let me see one other spot. So you have the died in hospital. I don't know, yeah, I mean, you can infer it from this and then looking at the post-op complications to see what the denominator is there. But we should add it in. It's probably be very helpful for sites if we added it into this post-operative section as well. If you don't mind sending me an email, I think Nancy put our emails in the chat box. If you don't mind sending me an email, and I'll pass it on to IQVIA for an upcoming call that we have with them. And then I want to check in the, let me check one more spot in the risk adjusted in the benchmark reports. If it's located there. Hold on. As this is pulling up, I just want to thank everybody for joining today. This will be the last, I guess, the last question because we're at time. And we did really good at not going over. So thanks, Melinda. Thanks, Nancy. Thanks, my STS team. Sydney Clinton. Are you still there?
I am.
Do you want to give any update on public reporting while I pull this up?
I can. We are still working through the upcoming adult cardiac data refresh on the website, where the pages will update to reflect the 2024 Harvest 1 data ending in December 2023. We hope to have the website updated within the next 2 weeks. If you have any questions about your status or public reporting enrollment in general, please feel free to reach out to the public reporting inbox. I can put it in the chat.
Thank you, Sydney. Very nice update while filling time here for us.
My pleasure.
Where did I say that was? Post-operative information, I think. So that's good. It'll be coming pretty soon, updated pretty soon. And it's gonna, did you say it's gonna use the Harvest 1 2024 results, right?
For public reporting?
Yeah.
2024 Harvest 1, yes.
Okay, thank you. Yep, not here either. Okay, so we can work, send me an email, we'll work with IQVIA to get that added in. And I think that's it. No more questions. We're ending on time, 1 minute late. So thanks everybody for joining. I hope you have a great rest of the day. Enjoy summer. And if you're suffering from any of the weather that's impacted us, I hope you're safe and get back to normal soon. So thanks everybody. Take care.